In my practice, the majority of peripheral vascular cases are performed transradially, mainly because it's my main access site of choice for almost every procedure that I do. But I think globally, only the very high radial operators are comfortable enough to do peripheral vascular cases through the radial artery. So I think overall, I would say the majority are still performed femorally, but with high radial operators, I would say a lot of the radiologists who are doing high volume radial access are probably doing a lot of peripheral vascular cases transradially. I think in general, if you can do a case radially and you have the right equipment, it should be the default. There's good data showing low complication rate, faster ambulation, and especially in patients where, for example, in peripheral vascular disease, you have hostile groins post-surgery, or you have an endovascular stent graft in place. For a lot of these patients, radial access is much, much safer. It avoids the need for a closure device at the end of the procedure. And also the failure rate with closure devices in patients who have had surgery in the groin is much, much higher. So in my opinion, if you can, and it's feasible technically, radial access should be the default. There's no question in my mind that the best way to learn transradial access is to be trained by someone who's got a lot of experience, who's gone through a lot of the complications, the pitfalls, the challenges with radial access. And the only way to do that is to be trained formally in a formal setting. I think one of the biggest mistakes that radiologists make is they see radial access as an access site procedure only, and they don't look beyond accessing the radial artery in terms of potential pitfalls in the radial artery itself. And where most physicians seem to make mistakes is with regards to the equipment on the shelf. The equipment for femoral access is not translatable into the radial space. There's a specific equipment for radial access, in the majority that's been developed for cardiology, but a lot of the medical device companies have made great leaps forward in developing equipment that's specifically designed for radial access. And actually, one company in particular who has designed a radial to peripheral portfolio to make peripheral procedures much more accessible from the radial artery. I think if you look at the cardiology data, the data with regards to complication rates is settled. I don't think there's any point in going through research from a radiology perspective to show safety and efficacy. I think there's still a debate with regards to radiation safety, and we have one paper already showing clearly that the radiation dose to the patient and to the operator is lower radial compared to femoral in the liver. I think if we could do a simple study showing that all cases, regardless of what you're doing, are lower dose to both patient and operator from the radial artery, and I think it would be pretty easy to do, that would settle the debate. One of the debates that radiologists still have is this issue around stroke, and I think personally that's been settled in the cardiology literature. And although you can't translate the data specifically from cardiology to radiology with regards to femoral and radial access and the stroke rate, I think the vanishingly small incidence of stroke in general from radial access, whether you come from the right or the left radial artery, has been settled in large randomized controlled trials in the cardiology space. So from a radiology perspective, my feeling is some data just confirming what we already know with regards to radiation safety in the liver transferred into peripheral vascular disease would probably be the only thing that I personally think would be of benefit in the radiology space.